Slideshow.
Hello everyone, am I audible? Hello.
Good morning, everyone. I'll be presenting my thesis protocol. The title of my study is Assessment of Correlates of Neurocognitive Disorders and Behavioral and Psychological Symptoms, a cross-sectional study. So the introduction. So as we all know, neurocognitive disorders, they are a group of disorders in which the primary clinical
Need for the
yes.
directly go to the need for the study.
Yes. So the need for the study is as BPSD. So it is a it includes a variety of domains, and so these domains they vary with the type of NCD, neurocognitive disorder, and the severity. Also with the onset of illness, duration of illness, and the treatment received. So there is a need to study these correlates of NCD and behavioral and psychological symptoms, as each and every symptom has a different treatment, and it will help us in the early prediction and recognition, so that the treatment can be planned and individualized as per the requirement. Also, it will help the caregivers plan necessary support, and this should help the policymakers and other stakeholders in creating better facilities and service delivery for such patients. Also, not many studies have been done in India to assess the behavioral and psychological symptoms in neurocognitive disorders. And as we all know, 1/3 of total dementia care costs are attributed to the management of BPSD symptoms. Hence, it becomes crucial to evaluate and manage BPSD so as to improve both the patients and the caregivers' life. The aim of the study is to study the relationship between correlates of neurocognitive disorders and behavioral and psychological symptoms. The objectives are to assess the relationship between behavioral and psychological symptoms with the type and severity of NCD, to assess the temporal correlation, that is the onset of illness of NCD with behavioral and psychological symptoms, to assess the relationship between BPSD with the socio-demographic characteristics, including the risk factors in neurocognitive disorders. The inclusion criteria is patients of neurocognitive disorders fulfilling the criteria as per DSM-5, patients and informants willing to participate in the study and giving informed consent, patients with an MMSE score cutoff of less than 23. The exclusion criteria would be patients with any other serious psychiatric disease or severe neurological antecedents such as brain tumor, epilepsy, and inflammatory disease, patients without a reliable informant, and patients not amenable for MMSE. The tools which have been
Why the cutoff is 53?
so because the MS of the above 23 is considered as normal.
And any education criteria?
So
Education criteria के हिसाब से ना the NMC criteria would vary. Many times you might get someone here our context illiterate. So either you also put in our criteria with Hindi MMC.
So Hindi, so everything is in Hindi. So Hindi
Right here, Hindi
yes,
MMC.
Hindi
No, that is not considered
yes,
understood.
yes,
MMC is not Hindi MMC. So if you are writing doing Hindi MMC, you write Hindi MMC. So I've checked in Hindi MMC, the cutoff is 23.
So the tools I've used are the semi-structured performer to record the patient's particulars, the DSM-5, then LMSC.
You have written not written MMC, Hindi MMC.
Sir, I mentioned.
Holstein didn't give Hindi MMC. Hindi MMC is given by a different office, right? The
Yes,
as far as I remember. So you have to write Hindi MMC characteristics.
yes.
Change.
Mocha.
Hindi Mocha. This was discussed last week. Why this is not changed?
So then burden assessment scheduled by Tara. The neuropsychiatric inventory, the clinical dementia rating scale. The methodology would be the site of study inpatients and outpatients attending the geriatric clinic of Department of Psychiatry in SDRR. Study design is hospital-based cross-sectional study, sampling technique purposive sampling, allocation consecutive, and sample size all patients attending the psychiatric OPD fulfilling the inclusion and exclusion criteria within 1 year will be enrolled.
Why geriatric? Why geriatric? We have a formal learning center. So why so you can take patients also from geriatric clinic, but that if the site will stay only geriatric clinic, so you can take patients only on Friday, that too from 1 to 3 p.m. You cannot take patients on other days.
The procedure. Yes. So sample size 100 patients during 1 year.
All patients attending the psychiatry OPD within 1 year will be enrolled.
Yes.
So ये तो 100 से ज़्यादा हो गए, 100 से कम कुछ।
So sir ने बोला था minimum 100.
और वो भी 100 तुम कैसे पहले मतलब you have to, as you mentioned in the last presentation, you use the criteria, ठीक है, and then we can round off that to 100. ठीक, okay. So sample size will be formal last time.
Yes, sir.
You have to mention that. You have to mention that, but then say that 100 rounded up to 100, so minimum 100.
So उस formula के according 50 patients are there.
But only Alzheimer's.
No sir, I think NCD. So उसके according से 41 आ रहा था, वो भी फिर 50 कर दिया ना round off करके. तो फिर आपने बोला था कि 100 patients within 1 year ले लेना कि कुछ वो मत दो.
So minimum 50 करके मैं 1 year कर दूँ, okay? Because आपको बताना तो पड़ेगा आप 1 year छोटी भी कैसे आए. ये मतलब and you also have to in here only you also have to quote some study or some data from our institute की अगर तुम्हारा sample size minimum 41 आ रहा है, okay, कोई प्रॉब्लम नहीं है, लेकिन तुम ज्यादा ले रही हो कोई प्रॉब्लम नहीं है उसमें भी, बट तुम्हें ये बताना पड़ेगा कि हमारे बनिए में एटलीस्ट 41 पेशेंट्स आते हैं नहीं आते. How you calculate this 41?
So it was according to this prevalence rate and the sample error, and so it was put in a formula.
Whatever is the number, you just write the number, round figure minimum, but take all the patients and landing with you this one. इसकी लैंग्वेज चेंज करनी पड़ेगी ना, बिकॉज़ मतलब अगेन यू कैन नॉट ऑल अटेंडिंग साइकियाट्री ओपीडी फुलफिलिंग क्राइटेरिया भी बहुत मुश्किल है. तुम तो पर्पसिव सैंपलिंग दे रहे हो ना साइकियाट्री डिपार्टमेंट, कोई अगर सीधा एडमिट हो गया तो साइकियाट्री and site of study why you are writing patient outpatient psychiatry department secretary department and जब जहाँ वो inpatient outpatient आना है वहाँ आप ओपीडी लिख रहे हैं. सैंपल साइज में सैम्पलिंग टेक्निक में पर्पसिव सैम्पलिंग
सैम्पलिंग मींस जो आपके इंक्लूजन एक्सक्लूजन क्राइटेरिया होते हैं उसके हिसाब से आप साइक्लिक डिपार्टमेंट कर दीजिए इनपेशेंट आउटपेशेंट।
The following patients attending the psychiatry OPD will be screened by Hindi MMSC. Patients presenting with complaints regarding memory, patients suspected with neurocognitive disorders as informed by the consultants and colleagues. All patients more than 60 years of age.
Why you writing consultants and colleagues? The patient suspected with
initial screening
patient presenting complaints regarding memory, suspected with neurocognitive disorders, suspected with neurocognitive disorders. Okay. Don't write consultants just for private hospitals. Right? The right faculty. Don't write colleagues. Faculty is faculty. And 60 years. What about someone coming at 59? Day before yesterday, we got a patient with 50 significant memory deficits. So your analysis will tell you what is the mean age of all the patients. At least आप जो young onset dementia की definition है कि more than 40, मतलब 40 to 60 के बीच में हम young onset dementia कहते हैं या early onset dementia कहते हैं, 60-65 के पहले कहते हैं, तो वो patient हम मिस कर गए. Frontotemporal dementia generally they come at earlier age. स्क्रीनिंग के लिए वो क्लैरिटी नहीं आ रही है.
पॉइंट ये तीनों को असेस करेंगे, स्क्रीन करेंगे, इनको लेंगे नहीं. उसके बाद जो एमएमसी का क्राइटेरिया फुलफिल करेंगे लेस रिपोर्टेड उनको प्लेस मिल जाएगा. राइट,
यहाँ पे आप इसको चेंज करके फॉर डिफरेंट सेंटेंस को the following criteria the patients will be screened by the MSc in Department of Psychiatry. ठीक है, all patients presenting with complaints of memory. ठीक है, any patient having suspected neurocognitive disorder as per the description of faculties, and any patient with age more than 60 years. Okay.
A detailed history would be taken and mental status examination would be done to rule out any other psychiatric illness and any other comorbidity. Those fulfilling the inclusion and exclusion criteria will be requested for participation in the study. Written and signed informed consent will be obtained from the patients and their informants of the caregivers.
caregiver की definition क्या है?
So ये psychiatric inventory का जो PDF है.
What?
Yes.
Bachelor.
Yes. A semi-structured performer to record the patient's particulars, including identifying parameters and risk factors for incident will be filled. There will be assessed for multiple parameters as per scales used in the study mentioned above. Montreal cognitive assessment scale, the Montreal cognitive assessment scale would be applied to assess the patient's cognitive state. Neuropsychiatric inventory questionnaire will be conducted in part or entirely as an interview of the informant. If an informed observer is not available, the scale cannot be applied. The interview is best conducted in the absence of the patient to facilitate an open discussion of the areas that may be difficult to describe with the patient present. Clinical dementia rating scale would be applied to both the patient and the informant. Burden assessment scale by Thara et al. Would be applied on the informants. During the process of evaluation on clinical measures, uncooperative patients will be considered as dropouts, and this data would be used for statistical analysis.
Exclusion criteria में भी वो डाल neuropsychiatric inventory.
So not available for MSc.
कोई patient नहीं, if patient is available for MSc, but आप neuropsychiatric inventory नहीं कर पाए.
The informant, so patients without a reliable information.
हाँ, तो फिर उसके लिए वो स्केल नहीं लगा पाएंगे, तो दिस स्टिल यू इंक्लूड दैट पेशेंट.
No, sir, अगर NPI हो पाएगा तो
वहाँ पे ये क्लाइंट डालती नॉट अवेलेबल फॉर एमएनसी और इन्फॉर्मेंट reliable absence of reliable informant, subsequently leading to difficulty in application of clinical measures. Yeah, clinical measures, both like other clinical measures like NPI, which needs reliable informant. If the reliable informant is not present, we will exclude that. Then you're saying the patients and informants willing to participate in the study giving informed consent. How many patients we will see if we are suspecting dementia, we'll be able to give you an informed consent. The comprehension वगैरह होगा. And करने का मतलब है दोनों से लेना पड़ेगा. You have to say or. Announce the question.
Yeah, this one is asking a question online. It should be major neurocognitive disorders.
Yes.
Why? That was I was going to ask. Why change to? Was there any reason?
Yes,
If it
sir.
both mild and
Sir,
moderate.
mildly moderate. So mild. So because we have to assess the severity here. Sir, severity के साथ BPSD symptoms कितनी vary करेंगे? अगर हम already some major ले लेंगे, तो how will we?
Major and minor का criteria तो 23 same रहे.
Sir, according to sir DSM-5 में mild और major करके भी आ रहा है सब कुछ.
Correct, but MMSC cutoff then 24, 25 नहीं होगा.
Sir होगा. Sir MMSC sir less than 20. Sir that is screen less than 23. तो जितना भी आएगा वो they will be included in the study. Then we apply होगा. Sir मोका में ऐसे 26 से नीचे. And then sir 18 to 25. Then 10 to 18. Then below 10.
We see if you're taking mild becomes a totally different entity. Many patients will come under mild. आपको फिर आपने स्क्रीन कराया है, स्क्रीन आप मेजर न्यूरोकॉग्निटिव डिसऑर्डर्स के लिए करिए.
Major neurocognitive disorders are further divided into various severities. Okay, even Alzheimer's is divided. Even frontal dementia is divided.
वो subsequently mild, moderate, severe में divided है. यहाँ पे हम minor cognitive impairment की बात कर रहे हैं ना, MCI. MCI की patients नहीं लेंगे. We will only take major neurocognitive disorders who have dysfunction. आपके MCI में dysfunction नहीं आता.
Dementia ही नहीं हुआ है. ठीक है, मतलब उन्होंने और कैटेगरीज को डिवाइड कर दिया. They may progress with dementia. लेकिन आप हम डिमेंशिया हमारा इनिशियली यही रहता है कि डिमेंशिया की सेवेरिटी असेस करेंगे पीटीएसडी के वेरियस वेरिएंट्स से, राइट? ठीक है, लेकिन वो तो डिमेंशिया भी नहीं हुआ. दे इंक्लूडेड अदर थिंग्स व्हिच डजंट फुलफिल क्राइटेरिया डिमेंशिया एज द प्रीवियस कैटेगरीज इनटू माइनर.
ऐसे तो बहुत सारे पेशेंट आ जाएंगे जिनके आपके जो आप जब उनको स्कोर लगाएंगे वो थोड़े से उनके टू स्टैंडर्ड डिवीजन और वन स्टैंडर्ड डिवीजन के बीच कुछ स्कोर सब आप क्यों है माइल्ड कॉग्निटिव इम्पेयरमेंट एमसीआई में आ जाएंगे.
बहुत कॉम्प्लिकेटेड स्टडी हो जाएगी अगर हम दोनों.
Sir, everywhere I write major incident.
Major and check about MSc score cutoff for major dementia per se.
We can do a follow-up study, another study later on with mild patients after getting results of this one, but it will be very difficult.
यहाँ पे major करना पड़ेगा. And need for the study को और थोड़ा अच्छे से. Very important. If you will send your protocol for publication, आपका need for the study पढ़ते ही वो they might not accept it. It appears to be okay now. So need is why we are doing more clear regarding it. So that we discussed.
So that
Basically, you are mapping all the symptoms of BPSD, all the domains of BPSD across the various stages of dementia. So whether can we find any patterns? Specific dementias में कोई specific हमको BPSD symptom मिल रहा है at specific time duration, तो उनका temporal association है कि नहीं है, ना with the course of the illness, which might help us later on to plan the intervention. ये कहीं ना कहीं it should come out very clearly. That is why we are doing this. Okay. Your preferences and everything you have checked, like post style.
Yes, sir.
Why? Bibliography is very important.
You need to mention your references here also. When numbering of references. Okay.
Yes.
Even just you mentioned about MMSC, so you have to mention where you have referred to MMSC.
सारा चीज जो
From where you have referred its validity, its specificity, say Hindi version.
आपको देखना पड़ेगा and plus wherever you are using it for the first time, like in the MMSC, there you will give the reference.
That is okay, but there is one number in your presentation. Okay, in your hard copy also is not mentioned.
इसको तो आपके
So वो presentation में
दो है, एक नहीं है.
sir one
नीचे है.
5 7 2 3
वन दिख गया.
नहीं
वन गायब हो गया.
sir I yes sir.
Yeah. And when you will mention your Hindi MMSC first time in your presentation, whether in introduction or even in tools used, over there you have to mention reference of that also. Its validity, specificity, जहाँ पे you have to mention. ये वो data cast.
Review of literature. This is education.
Yes, sir.
itself. So when you write review literature, I think the last reference of introduction section was 7. So then this Mukherjee et al. Will come 8. Okay. And Mukherjee A will not come. You have to take it off A. If you are writing an author name, it will come only with the surname. And Bandyopadhyay, so you will not give Tushar Kanti. Okay? Bandyopadhyay at all. In the year you need not mention. जब हम लोग बैंक को रेफरेंसिंग करते हैं आप सीधा वहां पे नंबर डाल सकते हैं, आप ईयर हटा सकते हैं. एंड सिमिलरली उमेश श्रीकांत है ना, दैट उमेश विल नॉट edited properly. And continuity with the references, wherever you are writing your object, this inclusion criteria, MSc cutoff, from where you have taken this MSc cutoff. You have to mention reference there. DSM-5, you have to mention DSM-5 reference there.
Caregiver definition.
Caregiver definition. Yes.
So I should just write the number or should I write that?
No, nobody is a Vanco referencing style. वो follow करना है, उसका number लिखना होता है. Similarly, Dr. Ayushi, आपको सार्थक को करना है. Whether you have submitted your protocol final, right? And editing means, you need a lot of editing. There are a lot of, see the gap, spacing is not uniform. So spacing needs to be uniform. And then I think the font which they need for protocols, Times Roman, 12 font, and not double spacing. Generally, तो ये बड़े-बड़े fonts हैं काफी. Fonts भी हैं. Should you want to help them? Huh? You confirm it. Whatever is the. And when you are attaching scales at the last, at the end of the scale, you need to give the full reference to the scale. At the end of the scale also. There is a full reference to the scale. How you will take these references? How you will take these references? Does anyone know? कैसे करोगे? Basically, is Google running here? Can you display? एक बार Google खोलिए.
Yes.
Display होगा. निशानी एक बार.
ये वाली ये वाली
नहीं हो रहा
सर इसमें सिर्फ स्लाइड शो आता है।
नहीं, इसमें अगर आप विंडोज चेंज करें नहीं आ रहा है विंडोज सेटिंग विंडो है।
Am I audible?
आप गूगल पे जाएं, पॉकेट पे जाएं और पॉकेट में जाकर आपकी जो भी आपको आर्टिकल लिखना है उसका पॉकेट में आप जाकर वो आर्टिकल का नाम या ऑथर नेम या उसका टाइटल पेस्ट कर देंगे तो वो आपको नीचे आर्टिकल देगा। उसी आर्टिकल पे आप जाएंगे तो बदल में साइट ऑप्शन लिखा है, साइट जाके क्लिक करें। 6 to 7 रेफरेंसिंग साइट्स आर गिवन देयर।
यस
आप वहाँ से NLM है, जैसे IGP है, कैटेगरी would follow NLM or this Mango will follow EPA. Whatever is that, you click that option, you will get it, you will get the desired reference. वहाँ से कॉपी करें और पेस्ट करें। Very very easy now.
सर वैंकूवर
हाँ ठीक है, आपने जिस पे डाला नहीं इसलिए
सर यस
but you need to edit it.
यस
आपका प्रोटोकॉल्स कर देंगे ऑथराइजेशन श्योर समझता उसका पता नहीं। नेक्स्ट प्रेजेंटेशन
कंटिन्यू
start.
The topic of our presentation is frontal lobe anatomy and functions at my moderator Hina. So in this presentation we will be going through an introduction of cerebral hemispheres, then the anatomy of frontal lobe, functional areas of frontal lobe, the blood supply, and the functions of the frontal lobe. So our brain is basically divided into two halves by a longitudinal fissure, into the right cerebral hemisphere and the left cerebral hemisphere. So the cerebral hemisphere or the cerebrum, it is the largest and the most developed part of the brain. It contains the primary motor and the sensory cortices. So here, as we can all see in this diagram, so the external surface of cerebrum, it has basically gyri and sulci. Gyri are these upfoldings of the brain, and then these are separated by sulci. So we have some major sulcus shown here in this diagram, and these major sulci, they are responsible for dividing the hemisphere into various lobes. For example, this one is the central sulcus. It separates the frontal lobe from the parietal lobe. Then here, this is the sylvian or the lateral fissure. This separates the frontal from the temporal lobe and the parietal from the temporal lobe. And the last, we have the parieto-occipital sulcus. This is basically an imaginary line. It separates the parietal from the occipital lobe. So the brain cortex, the shell of the brain cortex, it is basically gray matter, and then there is a core of white matter, and then in the white matter we have some gray matter nuclei. The internal white matter, it contains association fibers which are limited to each hemisphere, the commissural fibers which link the corresponding areas of both hemispheres, and the projection fibers, which connect the cerebral cortex of each hemisphere with the subcortical regions, brainstem, and the spinal cord. For example, in this diagram, these are the association fibers which are present in the same lobe. The commissural fibers, which connect the corresponding areas of both the lobes, and the projection fibers, which connect the cortex to the subcortical areas and the brainstem. So the frontal lobe, it is the largest part of cerebral hemisphere. In humans, it reaches full maturity around the late 20s. A small amount of atrophy, however, is normal in the aging person's frontal lobe. A decline in frontal lobe volume of approximately 0.5% every year seems to be average. So the location of the frontal lobe. This is the frontal lobe. The frontal lobe is delimited from the parietal lobe by the central sulcus. And then medially we have the longitudinal fissure, and it is separated from the temporal lobe by the Sylvian fissure. Now we have various sulci and gyri of the frontal lobe. So this is the central sulcus, and this one is the precentral sulcus. In between the precentral sulcus and the central sulcus, we have the precentral gyrus. Then we have three superior frontal gyrus, middle frontal gyrus, and the inferior frontal gyrus, which are separated by the superior frontal sulcus and the inferior frontal sulcus. Now this is the lateral fissure or the Sylvian fissure. It has two rami. This is the ascending rami and this is the horizontal rami, which divided into this orbital part into three parts: the pars opercularis, pars triangularis, and the pars orbitalis. Now we come to the functional areas of the frontal lobe. So this is the central sulcus, and then we have various functional areas in the frontal lobe, and we'll be going through each area one by one. So the first one is this in the precentral gyrus, the area Brodmann area 4, which is the primary motor cortex. It corresponds to the precentral gyrus, and the primary motor area, it basically has a motor homunculus, which is of the opposite half of the body, and it is an inverted homunculus. Also, for example, this is the motor homunculus. The striking feature here is that the body part which has more fine movements, it is represented in a more larger area, and the areas which have lesser fine functions, it is represented in a smaller area. For example, the tongue, the lips and jaw, the fingers, they represent a more larger area. Anatomically, these areas give rise to projection fibers that form the corticospinal and the corticonuclear tract. The motor cortex receives major frontal lobe association fibers from the premotor cortex, the supplementary motor area, and also fibers from the insula. It is probable that these pathways modulate motor cortical activity in relation to preparation, guidance, and temporal organization of movements. Then we have this area, Brodmann area 6, the premotor area. The premotor area, it lies just in front of the primary motor cortex. Now, functionally, it is divided into a dorsal and ventral area. The neuronal activity in the premotor cortex has, in relation to the preparation of movement and the movement itself, has been extensively studied. The direction selectivity for movement is also a common feature of many premotor neurons. The dorsal premotor area, the dorsal premotor cortex, it has a role in motor preparation in relation to internally guided movement, and ventral premotor cortex has execution of externally guided movement in relation to a specific external stimuli. Then we have the frontal eye field, which is the Brodmann's area 6, 8, and 9. It lies in the middle frontal gyrus. Stimulation of this area causes the conjugate eye movements. The supplementary motor cortex. The supplementary motor cortex, it basically lies medially to the area number Brodmann area 6, that is the premotor cortex. It extends from the most superior lateral part of the medial surface of the hemisphere. Its role in the control of movement is primarily in complex tasks that require temporal organization of sequential movements and in retrieval of motor memory. Stimulation of this area in conscious patients has been reported to elicit the sensation of an urge to move or an anticipation that a movement is about to occur. Now, this green one, it is the prefrontal area. So the prefrontal area is the area excluding the primary motor, premotor, supplementary motor. So the premotor area, it predominantly has Broca's area, Brodmann's area 44 and 45. See, so the Broca's area, it is the Brodmann's area 44 and 45, it lies in the dominant hemisphere. Injury to this Broca's area results in difficulty in articulation of movements. That is, the comprehension is intact, the understanding is intact, but the patient has difficulty in articulation. It is also known as the non-fluent aphasia or the expressive aphasia. Similarly, we have Wernicke's aphasia, which lies in the temporal lobe, Brodmann's area 22. Here, the comprehension is impaired. That is, it has a fluent aphasia or jargon speech. Now we'll come to the blood supply. So the brain, it is a very vascular organ, as we all know, and it receives around 15% of the cardiac output and 25% of the oxygen consumption of our bodies. So the blood supply to the brain, it is via two major arterial systems, the internal carotid artery and the vertebral arteries. So here in this diagram, we can see this is the arch of aorta. On the right side, we have the brachiocephalic trunk, which is then divided into a subclavian artery and a common carotid artery, whereas on the left side, there is no brachiocephalic trunk and there is a direct division to the subclavian and the common carotid. The common carotid artery at the level of C4, it divides into internal carotid and the external carotid. So the external carotid artery, it basically goes and supplies the vessel, the face, the scalp, and the internal carotid artery via the foramen macerum here, it enters into the brain. Also, we have these two ventral arteries coming from the, which are branches of subclavian artery. These are going through the transverse foramen of the vertebral column, and they enter via the foramen magnum at the base of this brain. These are the internal carotid arteries and the vertebral arteries at the base of the brain form an anastomosis, which is known as the circle of Willis. Now, from here, the circle of Willis, we can see here, these are the two vertebral arteries. Then they give branches to the cerebral arteries, which supply the cerebrum. And then we have the basilar artery, from which pontine arteries come out, which supply the pons. And then the posterior cerebral and then the anterior cerebral arteries. So basically, the anterior cerebral arteries, it supplies the frontal lobe. The middle cerebral artery, it supplies the parietal and temporal lobe, and the posterior cerebral artery, which supplies the occipital lobe. So, if there is any infarct or any stoppage to the blood supply to the front in the anterior cerebral artery, so there will be features like aggressive antisocial behavior, personality changes, urge incontinence, apathy, abulia, primitive reflexes will be seen. For example, the grasp reflex and the whooping reflex, and gait apraxias. Now we come to the most important part, that is the frontal lobe functions. So basically, the frontal, we use the terms frontal lobe functions, executive functions, prefrontal functions synonymously. But the frontal lobe functions are different from the prefrontal lobe functions, because the frontal lobe functions include the more basic functions that are not considered to be the higher order cognitive functions. Also, we use the term executive functions synonymously with the term prefrontal lobe functions. But the executive functions, they comprise a majority of prefrontal lobe functions, but not all. So the functional anatomy of the prefrontal cortex. The prefrontal cortex is divided into the dorsolateral prefrontal cortex, the superomedial, the orbitofrontal, and the frontal cones. So there are basically a lot of models to understand the functional neuroanatomy, but none of the model is universal. Here I've mentioned the model by Stuss and colleagues as in the American Academy of Neurology, and 5 component processes have been identified as separate prefrontal lobe functions. First is energization. It is the process of initiating or sustaining any non-reflex response. It is any activity that requires getting one's mental clutch out of the neutral position, that requires energization. So deficits in energization were associated with bilateral damage to superomedial prefrontal cortex. Whereas damage to the frontal cone causes impairment of metacognitive processes, including the self-awareness. Orbitofrontal cortex, we see it is responsible for behavioral and emotional regulation, and the dorsolateral prefrontal cortex is important for task setting and monitoring. Task setting refers to developing and implementing a plan for carrying out activities, for example, paying bills, whereas monitoring is the process of checking that one remains on task over time. So first we'll come to superomedial prefrontal lobe functions. So deficits here leads to deficits in energization. If there is a severe deficit, there can be akinetic mutism, that is a total inability to initiate any internally derived activity, but with intact basic sensory and motor functions and retained ability to react to external stimuli. When there is a less severe deficit, that is reduced initiation of motor, cognitive, or combined psychomotor responses despite preserved basic attention. So we should keep in mind that apathy should not be confused with the term depression. So we can differentiate between these two by a apathy evaluation scale here, which is self-rated. And so it is a apathy evaluation scale is an 18-item scale with higher range is suggesting more apathy. Another test known as the phonemic or lexical word fluency test can also be is used. That is, in this test, we ask the patient to produce maximum number of words in 1 minute by a particular letter. So the ability to generate words by a particular letter can be a useful index of energization. So now the dorsolateral prefrontal functions, as we all know, it has two functions, task setting and monitoring. It is also important for working memory. Patients with difficulty in task setting may be able to complete a previously learned routine, but will have difficulty in carrying out something new. In more serious cases, completing even familiar tasks can be impaired. Now the tests for executive functions or the DLPFC is, first we have the digit span test, in which we ask the patient for forward and backward digit span. Then the Luria hand sequences, that is the fist edge palm test. Now a written equivalent of the Luria hand sequences is alternating square and triangles test or the multiple loops task test. For example, here we can see a patient was asked to draw a triangle, this pattern, the dotted pattern, but the patient, and he was asked to start from one end of the page and continue it to the other end of the page. The patient made an initial task setting error. Instead of beginning with a square, he began with a triangle, and then he continued with an incorrect sequence of triangle, triangle, square instead of the square, triangle, square pattern. So this is a monitoring error. Then we have the go-no-go task test and the conflicting instructions test. This is another, this is the multiple loops task test. In this test, the patient was asked to make the dotted pattern, and in spite of multiple instructions that you have to start from one end and reach to the other end horizontally of the page, the patient proceeded to copy the pattern downwards, vertically instead of horizontally. That is a task setting error. And the patient also started making monitoring errors. Some of his triple loops are double loops. Then we have the trail making test, which is a sensitive measure of the executive function of the DLPFC. It has two parts. Part A, which is sensitive to energization defects. That is the basic motor speed and visual search speed, but it also tests the basic visual motor attention and scanning. Part B relies more on the task setting, remembering to shift the mental set. This is the trail making test. The patient was instructed to draw a line going from one number to the another number. Then we have the phonemic or lexical word fluency test. It is sensitive to medial frontal damage due to decreased energization, resulting in reduced initiation and production of responses. However, successful completion of this task also requires planning and searching, as well as language processing. In fact, impairment in lexical frequency is greatest in DLPFC damage. Then we have tests of abstract thinking. Proverbs here are not a reliable test for prefrontal functions, because many people with a normal prefrontal function will not be able to correctly interpret a proverb that they've never heard. Also, we have the visuospatial function test. In this, the patient is asked to copy a particular item, for example, cube, and then a clock drawing test. For example, this is a clock drawing test. The patient was given a blank page and was instructed to draw a clock and put the numbers in sending and 10 past 9. So he put the numbers in the counterclockwise direction. That is a monitoring error. And he set the time at an irrelevant option and did not clearly indicate a longer minute hand. That is a task setting error. Now the orbitofrontal functions. The orbitofrontal functions are associated with behavioral disinhibition, emotional dysregulation, and altered social cognition. So the patients with OFC lesions will perform normal on executive tests, and hence clues to the orbitofrontal dysfunction usually arise in careful history taking. Questions regarding the patient's personal neglect, perseveration and obsession, hoarding, socially inappropriate behavior, excess jocularity, poor judgment, impulsivity, aggression, hypersexuality, hyperphagia, altered food preferences, environmental dependency should be asked. Frontal behavioral inventory is an assessment questionnaire which can be used to probe the spectrum of behaviors. Then at last we have the frontal pole functions. Frontal poles are involved in metacognitive functions such as being able to take the perspective of others and self-awareness. This involves perceiving one's own and others' emotional states. The ability to be aware of one's own state of mind and that of others is called the theory of mind. So there are three theories of mind: the cognitive theory of mind, understanding what others think; the affective theory, understanding what others feel; and the cognitive theory of mind, being able to influence others' mental state based on one's own understanding of them. And it is also important in sympathy and empathy. So patients with frontal pole dysfunction may often have behavioral emotional regulation due to orbitofrontal cortex dysfunction due to the proximity of these regions, and tasks that require the participant to identify facial expressions corresponding to the emotions of subject could be used to assess the affective aspects of theory of mind. These are my references. Yes. Frontal assessment battery test. First, so the frontal battery assessment, it has various tests to check the frontal lobe. So first we'll do the Luria hand sequences test, that is the fist edge palm. So I'll explain to the patient. You have to follow the sequence. Fist edge palm.
He is a Hindi speaker.
Good, but needs to check. Okay. Now we have to do this again. So he's able to do so. There's no task setting error or even movement error. Now, if he is able to do it 3 times, then we score him 3.
First 3 times you say first 3 times you ask him to repeat with yourself.
Yes, sir.
And then ask him to do it continuously by himself.
Yes.
And not from one hand. First hand with the right hand and then from the left. One. Without observer, 0.
The next is go no go test. Okay. When I tap once, I tap once, you tap once. When I tap twice, you not tap. Okay. तो मैं ऐसे अपनी कॉपी करती हूँ। 2 बार मारूंगी तब नहीं करूँगी। Then we have the conflicting instructions task. When I tap once, you will tap twice. When I tap twice, you will tap once.
ये और कराना है पहले आपको 3 बार रिपीट कराना है टैपिंग वंस टैप ट्वाइस 3 बार कराना है tapping twice, tapping once, 3 बार. Then you have to give him series of sequences. आप एक बार कर रही हैं 2 टैप, फिर एक बार 1 टैप कर रही हैं, तो then next time you might anticipate कि आप 2 टैप कर रही हैं, तो फिर anticipation सबसे करेंगे. So you have to then mix those series and then ask him to do it. So in order to आप 3 बार लगातार सिंगल टैप करें, फिर अचानक से डबल टैप कर लें. So you have to actually then see whether he is using his executive functions. Now to be aware and change his, that is more important. Okay. Utilization behavior है.
Then I bring my hands here and then I see the patient holds my hands or he does not.
ठीक है, इसीलिए नीज पे रखना है कि ग्रास्प कर पा रहा नहीं कर पा. यूटिलाइजेशन बिहेवियर है जनरली नॉट एक्सटेंडेड ग्रास्प होता है कि आप उसको हाथ ऐसे लेके जाते हैं, whether he is able to grab your hands or not, and you have to engage the patient in conversation. तो आप हाथ लाएंगे तो पकड़ लेगा, नॉर्मल भी हो सकता है. You have to engage him in the conversation. क्या बोल सकते हैं, बट आप उसको बोल सकते हैं छोड़ने के लिए, बट जब उसको ग्रास रिप्लेस है नेगेटिव रिएक्शन में छोड़ता नहीं. So which is the most sensitive test for frontal lobe suspect? Most sensitive overall, all of the frontal. You said ना lexical what you are saying. You said कि हम DLPFC के लिए भी जरूरी है ना, you have to see for the PCC. This becomes the most sensitive test. Time कम है तो at least lexical fluency या cognitive fluency कर लेना चाहिए. Kappa test. So Hindi version is Kappa test or animal living test. Animal living is very easy. कर सकते हैं. Kappa. It's Hindi version of it. Said person mass. Which is more difficult, similarity or dissimilarity? More difficult. किसी को डैमेज होता है तो पहले डिसिमिलैरिटी जाएगा या सिमिलैरिटी जाएगा? So, pointing out similarities की इस टेबल और चेयर में क्या सिमिलैरिटी है is more difficult to elicit rather than ये ना कि इसमें क्या डिसिमिलैरिटी है. So, similarities are more difficult. Dissimilarities are more easy.
Similarities are most sensitive. Many books also say you need not to do similarities. Similarities you get it. But similarities may be how much similarities is asked.
So in Leishman it was given that so we have to ask between three object similarities. For example, so the correct in table and chair the correct response would only be they are both part of furniture. In between for example rose and daisy they are both flowers, and then in between a banana and a mango they are both fruit. If he is able to tell these three, then only we will give him a positive score. Otherwise, all other similarities will not be counted.
कोई structured frontal lobe test पता है जो मतलब almost all these things they assess in a single shape test series or test battery
Frontal assessment.
or any other. That's what Bandel just told us. छोटा सा ही है, स्क्रीनिंग में OPD हो जाता है। ये क्लॉक ड्राइंग, नेमिंग, ब्रेड, you've done very well. It would have been, everything is fine, but at last you should all remember a table. अगर आप एक simple table बना लें कि ये चार part है frontal के, ये उसके चार हैं, and these are the tests, so that will be more simplified. मतलब it's very difficult to remember all these things, but once you have to do them in OPD or say in examination, so what you can recall, what you guys can do is have a table. It's a simple table. Frontal lobe divided into say, again you can follow any model. अगर आप ये कर रहे हैं तो orbital, frontal, dorsolateral, तो जो मीडियल और फ्रंटल पोल्स जो आपने डिवाइड किए हैं उसके क्या चार फंक्शंस हैं। एक का बस इनिशिएशन, मोटिवेशन, देन सेकंड का इमोशनल रेगुलेशन, देन कॉग्निटिव जो भी आपका सारे फाइंड आउट फ्रंटल। तो उनमें क्या क्या टेस्ट करते हैं, तो आप वो बस रिकॉल अच्छे से बना के रख लें तो बस। You don't need to remember all these things, but and how to perform all these things. इवेंचुअली आपको वो एक टेबल याद होनी चाहिए कि किस पार्ट में, चार किस पार्ट में डिवाइड किया, सब बुक्स डिवाइडेड इनटू 5, सब में 4, उनके क्या क्या फंक्शंस हैं और क्या क्या टेस्ट करते हैं। सिंपलीफाई करने के लिए
No comments. Huh? I think it was an excellent, very good presentation. After a long time of hearing such a good presentation in this house, you've covered everything. You've gone out of your way, blood supply, you've shared anatomy, the sulcus. You could have actually gone away with a lot of things which are little out of the comfort zone. The presentation could have been simple, more simple, removing most of the complexities, but you thought of including all those. So I think great should be.
Stop sharing. Stop share.